Hi everybody, welcome back to EMT Review Episode 2. In our previous episode, we discussed pulmonary embolism. I did mention that in the next one, we're going to be doing spontaneous pneumothorax. However, before I do that, I want to discuss patient assessment. And then I'll drop another episode today as well for spontaneous pneumothorax. Patient assessment. First of all, this is just a quick review. This is not in lieu of learning it properly and thoroughly. The purpose of a patient assessment is basically to get your general understanding of what is going on now with this patient, giving necessary or administering necessary interventions, and gathering information and being able to give that information over to whoever is receiving the patient. We basically have our 4 sections. The first section is the preliminary section before you actually get to the patient, making sure that the scene is safe, PPE, and so on and so forth. Second is you're assessing and treating any life threats. That's the level of consciousness and ABCs. Section number 3, that is going to be investigating the chief complaint using the OPQRST, getting a little background using the sample. And then the 4th section is taking vitals. Now, the preliminary, before I get to before I even get to the scene, I have my dispatch information. I'm en route to the scene. When I get to the scene, I'm going to make sure that the scene is safe, make sure I got my PPE on. I'm going to make sure I get my general impression of where I am, understand what's going on. And then, of course, general impression of the patient themselves, making sure this is my only patient. If it's necessary to call any additional backup, or additional resources, ALS, police, fire, it may not necessarily be evident yet whether I need ALS backup or not. Once I get to the patient, I want to introduce myself and ask them for, the chief complaint. While I'm doing that, I'm essentially assessing my level of consciousness and ABCs. Level of consciousness, I'm going to be using the AVPU scale. Alert, if they're looking at me, they're alert. If they're responsive to verbal stimulation, that's VP. Responsive to painful stimulation, or are they unresponsive? Then I'm going to go through my ABCs. Airway. Only if the patient is unconscious do I actually need to check their airway. If they're talking to me, obviously their airway is open. Then B, breathing. I'm just going to get the general impression of their breathing. I'm not counting their breaths, just do I notice any struggle or difficulty breathing or any noisy breath sounds? If there is any difficulty breathing, I'm going to sit them up, give them oxygen, call for ALS. C, circulation. I'm going to get my general impression of the pulse. I'm going to feel for a radial pulse. I'm feeling for general impression, rate, rhythm, and strength, and the skin, color, temperature, and moisture. At this point, I should know if this is a high priority patient or not. I should have enough understanding whether I need to call for ALS or not. Remember, the criteria for calling for ALS is any threats to their airway, breathing, or circulation. Then I'm going to investigate the chief complaint. Now, I should have made a transport decision already whether this is a high priority or not. Now I'm investigating the chief complaint. Using the OPQRST onset, what were you doing when it started? Provocation, palliation. Anything make it better or worse? Now, for pain, you're going to ask about quality. What type of pain? Describe the pain. R, region radiation. Where is the pain and is it radiating anywhere else? S, severity scale of 1 to 10, 1 being the least, 10 being the worst pain you ever had. And time, when did these symptoms begin? Not always is all of this going to be relevant for every call. If it's not not for pain, then you're not going to ask about the QRS. That's not going to be relevant. And I want to get a background sample. Signs and symptoms, I kind of got that already. I'll ask about allergies. Do you have any allergies to anything? Medications? Do you take any medications? And if you do take medications, have you been compliant? Have you taken your medication? Past medical history, not only did this ever happen to you before, but also any general medical history. And last, oral intake, what and when did you eat last, and events leading up. Then I should have enough of an idea at this point of what's going on. I'm going to give any necessary interventions as it comes up, as it becomes clear that they require it. And then I'm going to do my 4th section, taking vitals. Vitals is basically, I'm going to get exact number of breaths. I'm going to count the breaths. I'm going to get their oxygen saturation. If I didn't do that already, I may have done that in my primary. And I am also, if I'm in a place where it is the practice of EMTs to auscultate lung sounds, I'll auscultate lung sounds at this point. C, circulation. I'm going to count the pulse, get an exact beats per minute. I'm going to take the blood pressure. Now, if it is relevant to take their glucose because they're altered mental status, then I should have done that beforehand. Basically, right after my ABCs, any patient's altered mental status will add in D, neurological disability. I'll check for glucose. I'll do the B-FAST, which is the scale when it needs checking for a stroke, or consider other possibilities of why they may be altered mental status. Remember, these are our 4 sections. Always make sure you know where you are. If you get lost, stop. Where am I in my assessment? Get back to where you are in those 4 sections and take it and continue from there. Once you're done, of course, obviously, you're going to give over a patient report, basically of all that information that you collected to the receiving ambulance crew. All right. Meanwhile, have a great day, and we'll see you in the next episode.